would like to welcome our speaker today. We have Dr. Jessica Drummond, who is the founder and CEO of the Integrative Women's Health Institute. Welcome, Jessica.
Hi, thank you so much for having me. It's my pleasure to be here, everyone. And let's dive right in and get started. So, we're going to be talking today about nutrition for hormone balance. And of course, this is a huge topic. So, we'll be taking a little bit of a broad view with the understanding that it is actually normal for hormones to have some shifts through the month, through different phases of life. And also, we want to do everything we can to support those shifts so that they are less symptomatic for women. So we're going to talk about where hormonal balance begins in the body, getting to really the deepest foundational part of hormonal health, which for me is around nervous system optimization and metabolic optimization. So stress resilience, blood sugar and insulin balance, and the menopausal transition and how we can support reproductive hormone balance during that phase. And we'll look at the impact of thyroid hormone health on reproductive hormones. And then we'll be talking today about how lifestyle medicine, such as nutrition, exercise, and the nourishment of stress balance, support networks, nourishment for women with hormonal imbalance-related symptoms really goes far deeper than just food and supplements to also include lifestyle. Now, why are we dealing with so much kind of symptomatic hormone imbalances? And why is this starting so young? So in my practice, I work primarily with women with endometriosis or other chronic women's health conditions like PCOS or the symptomatic perimenopause or postpartum. And more, I'm seeing, 17, 18, 19, 20-year-old women and girls struggling with amenorrhea or irregular cycles, heavy cycles, a lot of fatigue, insomnia, hair loss, and these symptoms that we track back to hormonal imbalances. And, I really think that the root of this kind of in the Western world is all about stress and how we manage stress, how we balance stress, our expectations for, what people should be able to do in a day. And, so many of my clients are overachievers, type A, high achieving girls and women. And again, this starts really young. They'll be playing varsity sports, volunteering, working, taking AP classes, and dealing with underlying chronic illness, fatigue, life stressors, maybe moves, parents getting divorced, their own kind of social emotional friendship issues at school, dating, right? So this all starts so early, and there's really not a time where a young woman's foot comes off the brake, and so comes off the accelerator. And so then she transitions to college and she may layer on drinking, staying up late, all-nighters, and still doing everything she was doing in high school. And then there's a challenge often with infertility prior to pregnancy. And again, women are doing really just a lot, just fast-paced, very little attention to rest, recovery, even very little focus on sleep quality, sleep hygiene, and different phases of sleep. So when you have this, starting from, kind of the tween years and not stopping at all up until women hit perimenopause, where sometimes they just are stopped by the hormonal symptoms themselves. They're struggling with insomnia. They're so brain foggy that they can't keep working. They start having osteoporosis symptoms, although even and at least osteopenia, osteoporosis may show up on bone density scans, even if they don't fracture until later. And again, that can even start back with the, high school athletics, undernourishing, overtraining. There's just such an intensity to the life of my clients. When you contrast that with what we know is sort of a optimal plan for longevity from all of the blue zone data, there's much more rhythm to the day, social support, physical work, not so much exposure to blue lights and screens. There's a slower pace, there's more balance, there's more movement and fitness, but not at the level of spin class and, high intensity interval training for 45 minutes, not just, maybe 10, 15 minutes that the literature better supports. So I think, when we peel it all back, there's a level of intensity and achievement mindedness that I think is at the root of all of this. So really, when we look at the data around things like hot flashes, women can have equal shifts in estrogen levels. And those who are symptomatic for hot flashes have more disruption in autonomic nervous system activation and the HPA axis. So I like to think of kind of starting each of my clients with asking them the question, where is your autonomic nervous system state most of the time? Are you living in sympathetic activation, fight or flight? Are you living in ventral vagus activation, calm, cool, collected, relaxed, joyful, healing, easy to fall asleep, easy to stay asleep? Or dorsal vagus activation, which is more of a freeze, feeling of stuckness, maybe depression. So where are you living most of the time? Ideally, we want our clients living most of the time in that nice ventral vagus activation, rest and digest, if you will, that is supported by affiliative behaviors that we'll get into in a little bit with other friends, family members, people that are supported, really having that strong interconnected web of support. And then HPA axis is also optimally functioning from the brain all the way to the adrenals, having that stress resilience should that system be called upon. But we don't want it to be called upon all the time. So when we think about, brain's activation related to stress, you have an activation of sympathetic nervous system, which will stimulate release from the adrenal glands of norepinephrine and epinephrine, or the HPA axis activation through from the brain, the hypothalamus, pituitary, adrenal cortex, where we get cortisol. And that cortisol, while adaptive to short-term stressors, over time, like literally running from a tiger, over time, you're increasing blood sugar, reducing insulin sensitivity, lowering growth hormone and T3, lowering the immune response, and increasing fat and protein mobilization, which again, long-term, that's a recipe for metabolic syndrome. So how can we assess this to make sure that our clients are staying in that nice ventral vagus activation? Now, obviously, we can do vagal toning exercises and things like that. But first, I just really want to talk to her about what is her history of trauma, what kind of trauma is she currently living in. It would be great to do. It's great to do in your practice ACE scoring, looking at trauma through the times of hormonal shifts, puberty, birth, currently medical trauma, what is her sexual trauma? What is her experience with feeling safe in her body and in her life? Because if she doesn't feel safe, there's no place to go, right? There's no place to relax and heal and recover. We also want to look at the top 3 stressors are in all the literatures around the closest relationship. So does she feel safe and healthy in her spouse relationship, immediate family? How financially safe does she feel? And are there any major illnesses she's having to deal with, chronic illnesses, whether they're her own or her family members, or day-to-day work stress? And then behind that, just after that, is chronic exposure to news, which again, if we think about those blue zone studies, if you look at how much news people were even exposed to, 25 years ago, you might watch the news once a day at the very most. You might read a newspaper, but it wasn't such a constant flow of news about the entire world, right? And then exposure to, most of the work now is not physical work, going out in the farm or even going to the shops and cooking and house cleaning and things like that. It's more computer work on devices that emit blue light, EMF exposure. And we're lacking a balance of supportive social networks off of social media. I mean, like in-person social networks and nature exposure. Without this, there's just this constant level of low-grade stress. So I always lead, even when I'm working with someone from more of a nutritionist or physical therapist clinical mindset. So those are my clinical licenses, are in nutrition and physical therapy. I always lead with the tool of health coaching. Health coaching is a communication skill set that helps me to really mindfully listen to each client, tap into what her goals are, and really listen to the stressors that she's having to navigate. And, then we can have a conversation. Are these stressors modifiable? How quickly can they be modifiable? What's the plan? What can we do to buffer that stress in the meantime? So your listening skills are very nourishing. And then not coming up with the goals for your client, not necessarily even coming up with the next step plan for your client, but planning to, over a period of time, I call this kind of the coaching container, the engagement that you're working with someone, realistically somewhere in the neighborhood of 3 to 4, even 6 months, where you're bringing attention to stressors, working on modifying them, and slowly implementing more and more lifestyle medicine, nutrition shifts that are sustainable for the long term. And then if we can't change the stressors, how do we balance them? The web of support is a tool that we use in our practice that really helps clients identify who are the people on their team who can pick up their kids, who can help with cooking, what resources do they have available to them, and how do they fit into the interconnected web of their physical social network? A lot of times people undervalue how they contribute to their social network and are very bad at both asking for and receiving support. Mindfulness practices cannot be overstated. The more mindfulness is practiced, the more resilient the kind of top of all of the hormone axes are, the brain. And that's where we have to begin. And then we can utilize, obviously, vagal toning strategies like loud singing and chanting, cold exposure, breath work to keep people resetting, even just like setting a timer on their phone every hour, every 2 hours, reset. What state are we in? Can we reset our state to ventral vagus activation? One of my favorite tools, it's really simple to use for people who have desk work, is to go to Spotify and get free 528 hertz music, which has been also shown to lower cortisol. Okay, so let's get a little bit more into nutrition. So in our practice, we also support ventral vagus activation and stress resilience by not constantly having clients eating in a way that's bouncing their blood sugar all around. So when we use continuous glucose monitors and heart rate variability monitoring to track what's going on, like how does the blood sugar in this client respond to different kinds of food? Everyone sort of starts out on a healthy, anti-inflammatory, Mediterranean-ish, paleo-ish, or more plant-based, depending on genetic factors. Do we need to tighten it up for metabolic reasons? Sometimes we do, but a lot of times we don't have to move to like a full low carb ketogenic or even full low carb paleo diet or low carb vegan keto food plan, because we realize that it's not always the food. Often it's stress or timing. So we, if we're kind of in that status of the client over a period of weeks is eating a high antioxidant, low sugar, high fiber, moderate to high fat, moderate protein diet, lower carb, although again, too low carb can trigger more of a stress response. And the most important factors of this food plan, homemade, organic as much as possible, but sustainable. And the challenge with some of the ketogenic literature, while even though it's really valuable to keep that blood sugar range quite tight and even activate ketosis, nutritional ketosis, is the data supports adherence to these diets in the 50 percentile or less. We need to create whole systems around this, integrating this kind of nutrition into the person's life. Otherwise, it's more of a feast famine situation. They'll like go all in keto and then they just give up and eat all cake. It's like all or nothing. So we have to be constantly in conversation about how delicious, how social, how pleasurable, what feels easy, what's their meal planning strategy, who can help with this, so that it's a joyful experience, or at least not a chore. Otherwise, it's very difficult to sustain and people just give up. So, but I really like tracking strategies because clients get to learn for themselves what pushes their blood sugar high, what pushes it low. And that can also trigger some just shifts because the devices are created with nudges that actually trigger people to change their behavior. And the other thing that I think is really valuable is using heart rate variability tracking. That is such a useful measure of moment to moment stress. We use a Garmin Vivo Smart 4, which doesn't show us pure HRV tracking, but it does give us what's called a body battery store, and it gives us stress scores throughout the day. So we can see during the day what kinds of things are triggering stress and what kinds of things shift out of that stress into that calmer state. And then we're looking for a nice recovery overnight. How much healing are we getting each night during sleep? So then we want to use supplemental support as needed. So ideally, we're testing ferritin. So in the brain, we need several things. We need low inflammation, which can come from diet and stress modification. And we need oxygenation. And we need brain neurotransmitter activation. And we need neuronal activation or neuronal health, which comes from fat. So does hormone health, which hormones and neural myelin are made of fat, and then lower inflammation. So steady blood sugar, oxygenation, and low inflammation. So we start with lowering inflammation, food, stress, antioxidant supplements, and there's a good antioxidant supplement combination from Biogena. And then you can add herbs, lots of culinary herbs, oregano, rosemary, ginger, turmeric, spices, tea and herbs and spices are such powerful antioxidants, even more so than colorful vegetables, just in terms of how compact they are. Omega-3 fatty acids. I like my clients who are struggling with any hormonal imbalances to have at least 2 grams a day of omega-3 fatty acids, in the range of 2 to 3 grams a day, to have the backbone of omega-3 fats for optimal cellular membrane function, and just to have the materials to make all of these communication molecules. Then amino acids to help with sleep, to help with calming brain neurotransmitters like serotonin and GABA. precursors such as 5-HTP, L-theanine, directly supplementing GABA in some cases, and CBD, which will also trigger the support of GABA a little more indirectly. Iron, I like to test it to be at least 70. And then it's ideal if you can combine it with some vitamin C and sometimes adding vitamin B12, methylated B12, if methylmalonic acid is low on testing. To nourish the HPA axis, we want fasting glucose between 70 and 85 and increasing to somewhere in the range of between 90 and 120 postprandial and recovering pretty quickly. To support that blood sugar stability, when food is either not enough or it's not really the issue, sometimes it's stress. Chromium is important supplemental support, berberine, 500 milligrams before each meal. Stress biotic, probiotic, and for some clients, I combine that with akkermansia, which is also been shown to balance blood sugar. And you need to feed akkermansia with things like pomegranate, cranberry, and then bitter melon, ginseng, and cinnamon, which again, you can do like cinnamon teas. There are lots of ways to incorporate a combination of supplemental support with a culinary pleasure, if you will. So what are the natural hormones, the normal and natural hormone shifts of the menopausal transition? Well, don't forget, how do we make hormones? Starts with cholesterol. And so when we're thinking about the hormonal shifts of perimenopause and menopause, or any time the hormones are low, the first thing we want to look at is, and this could happen at other times, such as like over exercising female athletes or, depletion postpartum. We want to make sure we have adequate fat. So estradiol is produced primarily in the ovaries. Small amounts are produced in the adrenal glands and some peripheral tissues, most notably fat cells. Most of the circulating estrone is derived from peripheral aromatization of androstenedione, which is mainly adrenal. Estrone is, of course, the estrogen that dominates in menopause, and these two can be converted back and forth to each other. And one of the things I always say to my clients is, I don't think it's a good idea to gain significant weight in perimenopause, menopause. Sometimes that's an issue, but it's also not necessarily a good idea to be excessively lean during this time. So, a few, a pound, a couple of pounds may actually be supportive. And I'm seeing that more and more clinically, although I don't have strong data to support that. But I think we do know that excessively thin women in older age are at higher risk for mortality. So there's a little bit of a bell curve. We don't want our clients gaining excessive weight, but we also don't want them excessively thin and lean in this time frame. Obviously, estradiol is much more potent than estrone and circulates at 1.5 to 4 times the concentration of E1 in premenopausal and non-pregnant women. Estradiol levels in men and postmenopausal women are much lower than in premenopausal women. So this study looked at 511 women across to kind of see what happens over time as the hormones are shifting into that last year, the final menstrual period. And they looked at that for up to 10 years. And what they found was that urinary follicle stimulating hormone, FSH, LH, and the estrone conjugates and progesterone were measured each day. They looked at algorithms to detect the hormonal patterns that were consistent with having that pre-ovulatory rise in estrogen, then a follicular phase shift in estrogen versus progesterone. They were looking at metabolites in the urine, as well as sustained and robust rise in progesterone metabolism, which you'll see if someone actually has an ovulatory cycle. And then based on that data, they divide the cycles into those that have robust luteal phases. And so they were ovulatory, and those that were not. And what they found was that over time, there was sort of, if you think about 10 years prior to that final menstrual period of menopause, there was a slow decline in the number of anovulatory cycles, and then it just drops off pretty precipitously in the last 3 to 4 years. Race, ethnicity, and smoking did not influence how quickly the ovulatory cycles declined, but obesity did have an impact. When women had a BMI of over 30, that was associated with having a longer cycle length. So, more time between periods over the 10 years, except at that last year, right before the cycles ended, they had much shorter cycles, statistically shorter cycles. And I think this is one of the most interesting slides in this whole presentation. I think what's really important and useful for those of us working with women during this time of quote unquote hormonal imbalance, while progesterone declines at a fairly steady rate, kind of a gently sloping decline, that is not true of estrogen, which is up and down throughout that perimenopausal phase. So there can be transient periods of relative estrogen dominance. And then as we know, a sort of defining factor of menopause, having hit menopause, is having elevated FSH over a sustained period of time. So women with that higher BMI excreted overall less LH, FSH, estrogen, and progesterone metabolites than did women with a lower BMI. And the largest difference was found in reduced progesterone. So already we're dealing with a decline in reproductive hormones, which is not necessarily going to feel very good. There's a lot of symptoms associated with that. And this is exacerbated particularly around progesterone with obesity. So progesterone is really helpful for things like good sleep and sleep quality. So this is something we want to watch out for in our overweight women who are having trouble sleeping in perimenopause and menopause. And this is just to show that progesterone levels are so much higher than estrogen levels. So they'll have a significant impact. And as I said, because progesterone declines at that nice sort of steady state, sometimes there is a relatively estrogen dominant experience. And then you can also, so there are these vulnerabilities, right, during this menopausal transition where hormones may be quote unquote out of balance. One is estrogen dominance. Two is the influence of stress. Alcohol, I think, is a really under-discussed conversation in women in perimenopause and menopause transition. It really shifts blood sugar, impacts sleep, increased risks at any amount of breast cancer. I think there, can worsen hot flashes because it changes the blood sugar stability. Overtraining, I think, is another thing we don't discuss enough. How many women are trying to lose weight kind of aggressively in their 40s in spin classes and heavy strength training classes. And then we also have to think about the influence of thyroid hormones. So women actually, and I want to give a quick word about testosterone. I am originally come from a background of pelvic floor physical therapy, so I care a lot about the resilience of the resilience of the pelvic floor muscles and also just vaginal health in general. So we have a lot of times in women in perimenopause and menopause, we think about vaginal atrophy and vulvar atrophy, but we don't talk as much about strength and stability of the pelvic floor. And sometimes the pelvic floor gets really tight because women are trying to protect against urinary leaking or fecal incontinence or prolapse. And testosterone is really important to the stability and strength and resilience of muscle as women transition into menopause. So women actually produce 3 times as much testosterone as estrogen before menopause, though it's still much less than in men. Levels of testosterone gradually decline because of increasing age, or they can abruptly stop with surgical oophorectomy. The most commonly described symptoms of androgen insufficiency include dysphoric, negative mood, unexplained fatigue, changes in sexual function, including lack of libido, but also lack of just energy in general, changes, reduction in cognition and brain focus, lots of brain fog and mild cognitive impairments, losing words, forgetting things, memory issues, vasomotor symptoms like hot flashes and night sweats, bone loss, and decreased muscle strength, including at the pelvic floor. So again, stress is really, I think, one of the most important things we have to constantly keep in mind. And not only does that influence the hormonal stress resilience of cortisol, but influences directly immune function and the gut microbiome, which will then communicate directly back to the brain. And this can end up with a feed forward loop of emotional stress that then triggers kind of physiologic biochemical stress in the communication between cytokines and dysbiotic gut bacteria directly to the brain. So during the perimenopause to menopause transition, women report perceiving more stress. Women in perimenopause report higher levels of stress than premenopausal women, but there is no measurable change in fibrinogen, an inflammatory marker. But they did look at cortisol shifts in menopause, and that last year, like the year right before the last menstrual period to 7 to 12 months or so into that very beginning of menopause. So that transitional year and a half to 2 years, there was increased cortisol, about 10 nanograms per milligram of creatinine during that last year and a half to 2 years of the menopausal transition. And those that had that cortisol shift, so they were experiencing hormonally at least more need to buffer stress, had more hot flashes, even if estrogen levels were similar. So this, I think, really circles us back to why it's so important for us to be mindful of thinking about stress as important as anything else when it comes to these hormonal shifts, if not more, when it comes to symptoms. And then this is a bit of a busy slide, but the hypothalamic pituitary adrenal axis directly interacts with the hypothalamic pituitary thyroid axis, and elevated levels of cortisol, that stress hormone that we were just talking about in women that are more symptomatic with vasomotor symptoms like hot flashes and night sweats, that will also inhibit that elevated cortisol will also inhibit TSH, will also inhibit the conversion between T4 and T3, which is the active thyroid hormone. And so unless we kind of handle that foundational autonomic nervous system state and healthy stress resilience, the rest of the hormonal cascade is going to be affected as well. And during menopause, there are also potential shifts in the health of the thyroid. So if the thyroid function starts to decline, we can have challenges with liver health and increases in fatty liver disease. There can be higher risk for cardiovascular disease and arrhythmias, increases fat storage and abdominal adipose fat gain, will break down muscles and have the muscles be less efficient at utilizing glucose. And when we have lack of thyroid support, we have breakdown in bone and difficulty in brain neuronal kind of self-healing, if you will, right? And rebuilding of the brain. So that's when we have issues of mild cognitive impairments in the late 40s and early 50s, that the data shows that within 5 years can become early stage dementia. So I think, and then when we think about how does this directly relate to gonadal hormones, estrogen, testosterone, and progesterone, when you have that shift, that lower T3, fatigue, mood disorders, weight gain, and it changes how the hypothalamic pituitary gonadal axis functions all the way at the level of the hypothalamus, also slowing down that entire axis. So then you're having even less estrogen, even less testosterone, which will reduce libido, which will reduce erectile function. And I think it's important to point out that there is erectile function in women very similar to that in men. The clitoris, when fully engorged and erect, is nearly, internally is a very solid, relatively large structure. It's not just this little kind of clitoral button that you see on the models. So, this is just as important for women as it is for men. So what are some of the systemic impacts of the estrogen decline? Estrogen acts in the kidneys to augment activation of vitamin D and also supports parathyroid hormone. Without that, we can have calcium wasting, which will impact bone health. And estrogen directly acts on the bone to activate osteoblasts, which help keep rebuilding the bone. Estrogens act directly on the heart and vessels to stimulate nitric oxide production, which is really important for continuous healthy vascular flow and endothelial health, which is a huge issue in women. So how do we ease this menopausal transition? First of all, we've got to always come back to the nervous system. Then we want to lower inflammation, optimize thyroid health, and mitigate the impact of the estrogen and progesterone declines. So whole foods, nutrient-dense nutrition. And again, because I've gotten over the last 25 years of, utilizing things like elimination diets and, different relatively restricted food plans, I'm really seeing a kind of a problem with that in the long term. These kinds of restrictive food plans, on one level, there's a healthy diet, right? Mostly vegetables, lots of healthy, animal or plant-based proteins, healthy fats at relatively high levels. So women have the fat resources that they need to build these hormones and neurotransmitters and everything else, neuronal myelin. But so, we kind of know that between a Mediterranean, healthfully composed vegetarian, vegan, and or paleo food plan, depending on genetics, somewhere in that range, people will land for sort of optimal nutrition. But when we get very restrictive about that for more than like a lifetime, for more than like a therapeutic window, which is sometimes very necessary to be very restrictive or specific, then what I'm seeing is that we're literally kind of creating eating disorder, an autonomic nervous system reactivity to otherwise healthy foods. I'm not about, just having people eat kind of any, Oreos all day that they want. That's not going to be useful. But I think the excessive restriction has to be mindful of what that does to the nervous system. And hey, even eating an Oreo from time to time should not scare someone so much that it triggers an inflammatory response, excessive inflammatory response. I think we're underutilizing exposure to nature. So as much as possible, how much time can your clients step away from their blue light devices and take a break? A friend of mine, Dr. Alan Christensen, years ago, created a term that I love and I require of all my students to do at least once or twice a year, ideally quarterly, is a 3-day sleepcation. So no exposure to devices of any kind and just relax, just sleep, just walk around outside, just be at peace. And for many women, the easiest way to do that is just go camping, right? So that's really valuable. Antioxidant and phytonutrient supplements and foods and herbs, including curcumin, resveratrol, oregano, rosemary, and dark chocolate. It's really important to eat in color. Again, this can be how food can be so nourishing and healing, but also pleasurable and inviting. You can't underestimate the power of sleep, mindfulness, social support, and access to feeling like women's nervous systems can really rest in a safe space. And if that's not happening in their home and their relationship, you need to deal with that. So how do we optimize gut microbiome? Once we kind of get the nervous system on board, and this is happening concurrently in practice, but the next thing to do is make sure your clients are having an awesome bristle for bowel movement at least once or twice a day, and have good, healthy, robust gut microbiome. Add prebiotics like chicory root, dandelion, Jerusalem artichoke, garlic, onion, leeks, asparagus, banana, oats, apples, cocoa, burdock root, yuccan root, and or dietary fiber supplements, probiotics based on lab results, and improve gut motility using manual visceral physical therapy and movement, breathwork practices, twisting postures in yoga, walking, swimming. And I really like motility supplements. Ginger and artichoke can help. And really make sure that your clients are hydrating. This is a huge problem. So adding electrolytes to 2 to 3 liters of filtered water daily. So how do we balance the parasympathetic and sympathetic nervous system? One of my favorite tools for this. So again, have your clients tune into this at least every hour or two, is just to slow it down, cover the right nostril, and breathe just through the left nostril, or from yogic practices, alternate nostril breathing, vagus nerve toning, cold swimming, showers, loud singing, things like that. Stimulate connection and oxytocin. Sex can be a form of nourishment, especially in this population. There's a bit of a chicken and egg conversation about maintaining levels of testosterone and frequency of intercourse in menopause, hugs, pets, laughter with friends. And I'm more and more seeing in my practice signs of dysautonomia. So again, back to nervous system optimization. Are your clients having kind of strange heart rate, blood pressure issues, dizziness, fatigue, or digestive motility issues, nausea, diarrhea, headaches, tingling in hands and feet? Then we want to do more, even more focus on brain support. In that case, a short-term ketogenic diet, swimming can be very helpful, breath work, things like Pilates that have people exercising more horizontally than vertically. It's not always pure POTS dysautonomia. There are many different kinds of dysautonomia, but exercising horizontally versus upright can be really helpful. And then optimization of thyroid health. Sometimes we just have to look at where are some of the deficiencies. Are they just having trouble converting T4 to T3? Do they have enough zinc, selenium, vitamin E? Maybe they need some ashwagandha for calming the stress response. So considering when it comes to thyroid, what are the nutrients that we need to support? We know cortisol inhibits TSH. So what is at the root of her stress? Can we make a plan around resolving that if at all possible? And if not resolving it, how can we balance it? In our practice, we use a tool called the Holistic Women's Health Assessment, where we look at different domains of health, and we present this from the beginning so the clients know they have so much that they can do to change their health. It's not so much about, the checklist of things that I recommend. What's their perspective on healing? Do they believe that healing this condition is possible? Do they believe it's possible for them? How strong are they feeling in their lives, not just from a musculoskeletal standpoint, but from an emotional standpoint, a resilience standpoint, a community support standpoint? How much do they devote time to rest and recovery? What are their rest and recovery practices? What does that look like? Do they feel really rested? There's a very big difference between laying on the couch, scrolling through social media and watching Netflix at the same time, and putting the device down and sitting outside in nature for 20 minutes. The restorative difference of that is very different. We ask about her resources, her digestive function, and anything she's doing to encourage detoxification, even breath work, sweating, things like that. To support the thyroid, avoidance of persistent exposure to persistent organic pollutants as much as possible is important. The thyroid hormone levels of people that were exposed to more persistent organic pollutants, even among newborns, that showed disruption of the thyroid as early as in newborn life. Cell phone exposure of 2 hours per day correlated with a higher than normal TSH level, lower than the mean of T4, but normal T3. But I'm thinking, well, we're on the path to some low thyroid challenges here. Any partial sleep restriction was accompanied by modest but statistically significant reduction in TSH and free T4, but only in women. And how many women during any times of hormonal disruption are having sleep problems? So many. The prevalence of vitamin D deficiency was significantly higher in those with autoimmune thyroid disease compared with healthy individuals, and also in those with Hashimoto's compared with those that did not have an autoimmune version of thyroid disease. Vitamin D deficiency also correlated with the presence of antithyroid antibodies and abnormal thyroid function tests. So optimizing vitamin D is one of the key things we can do in this population. So we want to support women to mitigate that impact of declining estrogen. So support adrenal health, not excessive leanness, kind of that nice bell curve balance between a healthy weight, but not gaining too much weight, not being excessively lean. And, think about when and where a very modest amount of weight gain could potentially be beneficial. Reducing inflammation, as we've talked about, low carb, nutrient dense, high fiber diets, sleep hygiene, stress balance, adding some adaptogens. The three I like the best are in this population. Again, I don't like to stimulate things. I don't want to get more blood out of this stone, but ashwagandha, tulsi, or rhodiola, phosphatidylserine, if we have clients who are struggling with high cortisol consistently, or licorice for very low cortisol. DHEA supplementation, Jova is one over-the-counter option, or I refer my clients for hormone replacement therapy assessment through physicians and other prescribers who are very experienced with that, including estrogen, progesterone, and testosterone supplementation. Melatonin for sleep support, and maca is wonderful for supporting low estrogen and low testosterone levels. To support testosterone, optimize insulin and blood sugar balance, exercise, especially strength training, but not overly intense. And as I said, intercourse frequency correlates with female testosterone level in the mid-cycle. During premenopause, masturbation, sexual desire, and arousal will positively associated with testosterone levels all the way through menopause. Again, we don't know if this is chicken or egg. The women that have healthier testosterone levels have healthier sex lives, or vice versa, but it's worth having a conversation about with your clients. So as we talked about, estrogen decline is not as straightforward as progesterone decline. During that shift from primarily estradiol to estrone, there are periods of elevated estradiol or estrogen dominance, sometimes depending on how quickly progesterone is dropping off in that same time. With reduced progesterone, which is worse for women who are obese, sleep can suffer and anxiety can increase. Testosterone decline can impact muscle strength, including the pelvic floor, mood, cognition, bone health, and sexual function. So our goal is to optimize the nervous system, keep women constantly reshifting back into parasympathetic ventral vagus nerve activation, and support HPA axis function, optimize thyroid health, exercise, but not to the point of overtraining and burnout. There's still a lot of body image issues in women who are 40s and 50s. Stress balance, which will help conclude the emotional stress cycle, is really important. And nutrition should be blood sugar balancing, relatively low carbohydrate, and nutrient dense. And I've created for you a hot flash relief cookbook that you can share with your clients or use for yourself. You can download it there at that link. And that will also be in the handout that you get tomorrow, I think. And then that's all from me.